Good morning, everybody. First, I would like to thank Professor Oskinis for this invitation. My talk going to be about critical limb ischemia, and will show you two clinical cases with two different pathology. First case, it's a 64-year-old male who has a critical limb ischemia with a tissue loss. We have a first attempt by a standard approach, retrograde puncture. We didn't see any tibial arteries at this origin, and we failed to recanalize. So we decided to convert it to a safari technique under general anesthesia because the patient has really a high level of pain while he was on the angio table. So here the intervention was done on general anesthesia. We punctured with a 4 French introducer the common femoral artery, and as you see the first angiogram, and we can see that there's no tibial arteries that was visual at its origin. And I want to show you, if I can go back just some of the slides out here. We saw that it was the origin of one of the tibial arteries, or posterior tibial arteries, but we'll see later that it was not. And here's the movie. We can see that there's a huge calcification of the posterior tibial artery, but this artery was patent and it had good outflow. Puncturing the distal part of the tibial posterior artery, we have put a 3 French catheter, and we have used a 2.4 recanalization catheter over a 01014 guide wire. We pushed, it was probably subintimal recanalization. We did find the good lumen, the interlumen on the distal part of the popliteal artery. We crossed with the catheter and the guide wire. And here we see that we were into the good lumen. We pushed the guide wire that was snared from a snare coming from above, from the introducers was in the common femoral artery. And here we have a through and through guide wire going from the common femoral artery to the tibial artery. We pushed a 3 millimeter diameter balloon, and we ballooned the occlusion of this tibial posterior artery, and we can follow the balloon going down, and you're gonna see very soon the angiogram. And here the first angiogram, we see that the origin of the tibial artery was higher than this branch. It was probably collateral, and the flow was not so good because probably we didn't dilate enough the distal part of the posterior tibial artery. And here the distal control. See, flow is not so good, so we decided to push the guide wire further and to take a 2 millimeter diameter balloon and pushed it very far in this tibial posterior artery in the plantar arch. And here we can see the final control with a good outflow. And in conclusion, in those cases, if you have a good outflow and a good inflow and a good outflow, so you will have a good outcome. That's what happens with this patient. The second case is a case of a 60-year-old male also. He had a history of popliteal occlusion with a critical limb ischemia. Here was the first, in 3 years ago from now, he had a angiogram and a recanalization of the popliteal artery. Here the angiogram, it was done by a contralateral approach. The SFA was okay, and when we are after the popliteal artery, there was an occlusion. And you have two good distal popliteal arteries that was patent. We succeeded to go with the guide wires easily, but the PTA was not efficient, and we decided to put a self-expandable stent in this area. And here's the control after the stenting. The result was okay, not very good, but it was just okay. And here we see the control with the knee that was bended. The stent occluded 6 months after, and the patient suffered again from critical limb ischemia. He got surgery with a popliteal tibial bypass and still no improvement. So he had a CT scan, angio CT for control. And here's the angio CT. See, we have an early opacification of the vein, of the superficial femoral vein that suspected a communication, AV fistula. That was the cause of the non-healing of this critical limb ischemia. And it was confirmed by a ultrasound Doppler, and there was no stenotic lesion. So we decided to go to another angiogram. And here's the angiogram. Here we see there's a high flow AVF fistula between the artery and the vein, and we did succeed to canalize this, to catheterize this fistula, but it was very difficult to put any type of coil or embolization material because the flow was very important. So we decided to go for a covered stent, and here we can see the positioning of this covered stent. It was a Gore covered stent, Aviaban, of 6 mm diameter and 5 cm long. Here we can see there was remaining a small AVF, but after ballooning with a 7 mm diameter balloon, this AVF disappeared, as we can see here. So in conclusion, if you have a high flow AVF, it may reduce distal flow, so it may be caused in non-healing critical limb ischemia. Embolization in those cases are some difficult, and cover stent are easy to use and give a very good clinical results. Thank you.